Orlina, a very good morning to all of you. It is my great privilege to have Dr. Diane Coffey with us. She has been a good friend, and one day we hope to work together as well. She is doing fascinating work in India, and I'm so glad that she has taken the time out of her busy schedule to be with us today. Let me start by introducing the topic and Professor Coffey. So today, the topic of the seminar is on skin to skin care, neonatal death and quality of care in public and private hospitals in rural North India. Professor Coffey is an associate professor of sociology at University of Texas, Austin, and co-executive director of RICE, a research institute for compassionate economics. She is a demographer who studies population health and social influences of health in India. An area of her research focuses on the intergenerational transmission of poor population health resulting from India's exceptionally poor maternal nutrition. Another area of her research finds consequences of poor sanitation in developing countries for early life health, including for mortality, height, and anemia. She has also studied the causes of open defecation in rural India. Her work has been published widely and in one of the leading journals in the field of demography, development, and economics. Some of those being Proceedings of the National Academy of Sciences, a Journal of Development Economics, Social Science and Medicine, Demography, amongst others. Without further ado, please join me in welcoming Professor Coffey.
All right, shall I get started?
Yes, please.
Great, great. Well, thank you so much for having me, and thank you so much, Kriti, for that very kind introduction. Um, Today I'll be talking about a few papers all relating to neonatal death and quality of care in public and private hospitals in North India, and the most recent of which I'll get to at the end is related to the new demographic and health survey question on skin-to-skin care. Um, And, it's a pleasure to be speaking at the National University of Singapore today. So before I um, jump into the talk, I'd like to thank my collaborators on the different papers that I'll be presenting. So that's Bishnupriya, Nathan, Alok, Lavi, Aditi, Nikhil, Dean, and Asmita. And I thank all of them for the journey that we've gone through together to understand neonatal mortality in North India better than we did when we got started with this. So a little bit of an overview of the talk today. I'll be giving some background on neonatal mortality in North India, and then discussing three findings. So one finding is that in rural North India, babies born in private hospitals are at the highest risk of death. They are at a higher risk of death than babies born in government hospitals and than babies born at home, which is somewhat surprising. The second finding is that although we think that selection into type of facility does play a role in this gap, it can explain the mortality penalty of being born in a private hospital entirely. We do comparisons of similar types of births in different facility types and find evidence that points to differences in quality of care. And then the third finding will be about rates of immediate postpartum skin to skin care. And we see that they differ both by the baby's own place of birth and the neighborhood of birth. And we'll use that variable about where a baby's neighbors are born to offer additional evidence that quality of care is importantly responsible for these mortality differences between facility types. So let me start by just telling you a little bit about the outcome variable that we'll be looking at. Broadly, we're interested in early life mortality, but we're going to zoom in on neonatal mortality. So let me put that into context a little bit. Demographers split infant mortality, the death of children under 1 year of age, into two groups: neonatal mortality, deaths in the first month of life, and post-neonatal mortality, deaths of infants 2 to 11 months old. And this distinction is a useful one because these two early life mortality rates have quite different causes. Leading causes of neonatal mortality tend to be about poor maternal health and poor healthcare at birth, whereas leading causes of post-neonatal mortality in low and middle income settings tend to be about respiratory and gastrointestinal infections. And so we'll be focusing on the deaths in the first month of life. And for those of you who are a little bit less familiar with the Indian context, it may be somewhat surprising that the variation in neonatal mortality within India is just about as large as some of the highest and lowest mortality countries in the world. So the context where I focus the most, rural Uttar Pradesh, has among the highest neonatal mortality rates in the world, 37 per thousand in the latest demographic and health survey. This is similar to Nigeria and Pakistan. And if we were to think of Uttar Pradesh as its own country, it has about 240 million people. That's a similar size to Nigeria and Pakistan, also very large regions, and they are responsible for a large fraction of the world's neonatal death. And so when I say that we're going to be focusing on North India, that's because that's a very high mortality region. Whereas if you compare even to a large state in the south, such as Tamil Nadu, you see that neonatal mortality is less than a third of what it is in rural Uttar Pradesh and Tamil Nadu. So there's a lot of variation by region, and we're going to be focusing on the highest mortality parts of India. So there have been some really important changes in healthcare at birth in North India in the last 2 decades. There's been a really large decrease in the fraction of births taking place at home. In 2005, in the what's called the NFHS 3, the National Family Health Survey 3, about 4 in 5 births in North India took place at home. By 2019, it was only about 1 in 5. And so for this first set of findings that we'll look at, we're going to look at a region of comprising the North Indian states of Uttarakhand, Rajasthan, Uttar Pradesh, Bihar, Jharkhand, Madhya Pradesh, Chhattisgarh, and Orissa. And together they comprise a high mortality region that has a combined population larger than North America, comprising 9% of worldwide births and 15% of worldwide neonatal deaths. And I'll say in a minute why we take this region in particular. But before I do that, I just want to motivate a little bit the reason for looking at public and private facility births differently or separately. So much of what's been studied about the consequences of hospital birth tends to default to focusing on government hospitals. And that's in part because there was a very large cash transfer program called Janani Suraksha Yojana, which encouraged facility births with mostly a focus on government hospitals, particularly in the states that I mentioned, that really spurred this transition from birth at home to birth in the hospital. However, I think private hospitals are really quite understudied, and they account for a relatively large fraction of births. So in the NFHS 5, sorry, I have it mislabeled there. It's the 2019-2021 data, or the NFHS 5. It was about 1/4 of births in India taking place in private facilities. And I think one reason why private facility births are somewhat understudied is because the demographic and health surveys don't have the sorts of information that would allow us to distinguish among types of private facilities. So some of you may be familiar with the sorts of well-resourced private hospitals that you might find in capital cities in India. This is an example of the Apollo hospitals. It's a famous chain. There's substantial medical tourism to India due to the high quality and low cost of many of the private hospitals. However, there's also a set of private hospitals or private clinics that are not staffed by formally trained doctors, and that exist to serve a lower SES population. And so here's an example of a operating theater in a private hospital in rural Uttar Pradesh, where an untrained provider may be performing cesarean births. And so when somebody in the DHS reports giving birth in a private hospital, it's a bit difficult to know whether it was a well-resourced hospital or a place with an untrained provider. And so the reason that we focus on people who are from rural areas is because they're much more likely to go to the less well-regulated and less resourced private hospitals. So with that, let me turn to the overall research questions of the talk. We'll be looking at how early life mortality rates compare for babies born in government and in private hospitals, and try to think about why these differences exist. And then towards the end, we'll talk a little bit about what sorts of interventions might decrease the high rates of neonatal mortality in this region. So I'll jump into the first finding, which is that in this region, rural North India, babies born in private hospitals are at the highest risk of death. And here we're going to be using the National Family Health Survey 4, the 2015, 14-15 data. And we have rerun the analyses with the NFHS 5, but I didn't have the graphs prepared for you today. So I'll just say that the patterns are identical, although the overall mortality rates are a little bit lower, representing health progress that we've been seeing in India for many years. And when I say North India in this part of the presentation, I mean that set of states that I mentioned earlier. And these are the National Health Mission's Empowered Action Group states. So they received special policy attention in 2005 when the government launched the National Rural Health Mission, and have continued to receive special attention as the National Rural Health Mission transitioned to the National Health Mission. So here are some sample means of neonatal mortality by place of birth, comparing rural North India and the rural parts of the other states of India. And so what you'll see in the orange is that the highest mortality rates are for births born in private hospitals among residents of rural North India. There's a big gap between the private facility births and the public facility births in rural North India that does not exist in the rural parts of other states. And you see the expected pattern comparing facility births in other states and home births in other states, where home births have higher mortality rates than facility births. But there's this interesting pattern in rural North India where the private facility births have the highest mortality rates, followed by the home births, followed by the public facility births. And, because ultimately we're going to be interested in what sorts of quality of care differences may exist between the types of facilities, we want to make sure that our story of quality of care is plausible. And so we look at not only death in the first month, but also death on the first day. And within deaths on the first month, death on the first day is most common. And it appears that there's the same pattern of mortality for death on the first day than for death in the first month. So in the next part of the presentation, we're going to be adjusting for some family characteristics. And normally when we think about, okay, we have a gap or a difference, and now we're going to adjust for the characteristics of, say, the group born in public hospitals and the group born in private hospitals, we do that because we imagine that it will reduce the size of the gap, that will have some explanatory power about the puzzle that we're trying to understand or solve. And I think what makes this story particularly interesting is that we're going to see the opposite thing happening. So public hospitals are much less expensive for patients than private hospitals are. Private hospitals charge substantially higher rates for births and for other services. And so the group of people who go to private hospitals for births are better off in a number of ways than people who go to public hospitals. The only difference, though, is that their babies are less likely to survive. So we're going to adjust for a variety of factors that are correlated with hospital choice and with mortality outcomes, such as the social background of the family, the DHS wealth quintiles, and whether or not the mother is literate. And when we do that, we're going to find that the gap actually increases, that this puzzle that we've been trying to solve only gets sharper. So I won't go into the nitty-gritty details of what we do, but basically we do a reweighting decomposition where we make the characteristics of the folks delivering in public hospitals similar to the folks delivering in private hospitals, and then see what mortality rates result from that. So another way of putting this is that these standardizations project what mortality rates would be if each setting, the public facility, the private facility, or the home birth, counterfactually had the distribution of the observables of all rural births, regardless of their facility choice. And you'll see some standard errors that we produce by bootstrapping the entire analysis, resampling with respect to the clustered and stratified survey design in the DHS. So this slide shows those results. And so again, the EAG states are North India. And again, this is just the rural parts. And so the solid markers that you'll see are just the simple sample means that you saw on the earlier slide, so without the reweighting. And then the hollow markers are going to be the reweighted or counterfactual mortality rates. And so the big takeaway here is that after adjusting for the socioeconomic profile of births, the gap between private and public facilities in terms of neonatal mortality in the northern states increases from 18 per thousand deaths to 29 per thousand deaths. So it's a substantial increase when we take into account that the people who go to give birth in private facilities are substantially better off than the people who give birth in public facilities. And that same exercise done on data from the rural parts of other states shows very little difference. And we didn't expect that it would. The mortality rates were not very different to begin with. And in the other states, all of the confidence intervals overlap. Simply out of interest, we put the data together, clubbed the data from all of rural India in the third graph. And because of the large population size and the large public-private gap that you see all the way on the left in the EAG states, that pattern dominates the data. And we see an all India public-private gap that's rather large when adjusted for socioeconomic characteristics in the third graph all the way to the right. And if we repeat this exercise just using mortality on the first day of life, we see the same pattern. And so this is beginning to build the case that care at birth could be an important part of what's going on in terms of the public-private mortality gap. And I just want to take a minute to step back and think about how large this difference is or how meaningful it is in terms of the number of deaths. So we do a very simple quantification that suggests that there are an extra 43,000 neonatal deaths annually that wouldn't occur if the births that happened in the private facilities had the same mortality rates as the births that happened in public facilities. And so just to give you a point of comparison, there were about 15,700 neonatal deaths from all causes in the United States in 2015. So this is more than 2 times, almost 3 times the size of all of the neonatal mortality in the United States. So it's a rather large problem that I think is worth understanding much better than we do. So now let's move to thinking a little bit about why we might see these differences. I think the first thing that many people think of, and I think it's certainly not wrong, is that there may be selection of what types of births go to private facilities and what types of births go to public facilities. So we'll talk a little bit about what evidence there is for selection, and then we'll make comparisons of similar births in the two facility types that I think starts to point in the direction of important differences in quality of care. So let me start by talking a little bit about the evidence that I think is there for selection or differences in the types of births that go to different types of facilities. So this is a paper that came out a little while back in Economic and Political Weekly, and it was based on qualitative research in North India, where we documented the role of government employees in contributing to the adverse selection or riskier cases ending up in private hospitals. So one pattern is that the government employees do refer patients to other facilities if the case is too risky. And on the one hand, that's something that they should be doing. So the way that the public health system in India is set up is that if a case is too complicated for the primary health center where the patient presents or the community health center where the patient presents, the staff are supposed to refer that patient to a facility that has more resources that may be able to handle that case. And some families are not able or not willing to travel to the facility that they've been referred to. And so they on their own seek care in the private sector closer to home. So that's part of what's going on. But another part of what's going on is that there are many instances where public sector employees receive compensation from the private facilities to steer patients in that direction. And so there's some financial gain to be had by shifting, especially the riskier cases, into the private facilities. And I think another part of what could contribute to the adverse selection of patients into private facilities is that in the private sector, patients have to pay and private sector employees have to get business from the patients. And so they have incentives to have good staff patient communication and less verbal and physical abuse of the patients than might occur in the public hospitals where there's less financial gain to be had from treating a patient well and having good communication. Another piece of evidence that the private sector may be seeing higher risk births is the large difference in cesarean births between public and private facilities. So there are very few cesarean births in public facilities in North India, although there is some effort on the part of the government to increase the availability of cesarean births. That said, I think that a lot of the difference that we're seeing, a lot of the high rates of cesarean births in the private sector may not be the private sector providing medically necessary cesareans for high-risk births, but instead promoting cesarean births or pushing cesarean births on patients that may not be medically necessary. So now that we've talked a little bit about the selection side, like what are the arguments in favor of selection, I'm going to show you some evidence that selection is not the whole story. So the first step that we take is to restrict our sample to lower risk births, vaginal births. And we see the same public-private gap, the same pattern of a public-private gap in rural North India and not in other states when we restrict the sample to lower risk vaginal births. If we then move on to looking at subsamples that are even lower risk, so conditioning on vaginal births where the mother was over 20, she has at least one living child, she has no prior neonatal deaths, and sorry, that's all for the first one. So vaginal births, mothers over 20, at least one living child, and no prior neonatal deaths. The neonatal mortality rates among that next child are 38 per thousand in private facilities, and 24 per thousand in public facilities. So a relatively large gap. If we further restrict to cases where the mother reports vertex presentation of the baby, so head down as opposed to a breech presentation, the overall mortality rates are lower, 24 per thousand and 16 per thousand, but the gap remains. And so that was us thinking about safe subsamples. Um, for the purpose of being thorough, we looked at many, many different subsamples. So ones where the mother had a prior death, she did not have a prior death, where the mother was under 20 at the birth of the child, where she was over 20 at the birth of the child, and where she had different underlying maternal health as marked by her projected BMI. In all of these different subsamples, we see substantial mortality gaps between babies born in public and private facilities. And the qualitative research that we did does support that there could be important differences in quality of care. So one thing that we found was that many of the providers who are interacting on a day-to-day basis with patients in the private hospitals lack formal training in maternal and newborn care. So it may be that there's ultimately a doctor associated with that hospital who has formal training, but he or she may not be present on a day-to-day basis when the deliveries are happening. And the untrained providers are more likely to perform C-sections and induce labor without medical indication. And particularly these C-sections or medical inductions of labor are interventions that we know can increase mortality relative to letting labor start on its own when it starts on its own. So the mechanisms for that would be through prematurity, birth trauma, and asphyxia. And there's medical literature that shows that these conditions, prematurity, birth trauma, and asphyxia, can negatively impact the initiation of breastfeeding. And so with the DHS4 or the NFHS4 data that we've been looking at, we look for a simple difference in the early initiation of breastfeeding as a way of starting to look at quality of care. So this is just a simple bar graph that shows breastfeeding within 1 hour of birth between public and private facilities. It's higher in public facilities. Breastfeeding within 24 hours of birth is also higher in public facilities. Ideally, we would like to put this into a more complicated framework, but this indicator of quality of care is missing for many of the babies who died in the first month of life. So we can't use it in a regression or a decomposition. It's not collected for many of the babies who died. And so this brings me now to the third finding that I was interested in sharing with you all, and it's about rates of immediate postpartum skin-to-skin care. And we see this as sort of building this case for quality of care. And we're going to talk about how now with the introduction of this question in the NFHS 5, we can look at how rates of skin-to-skin care differ by place of birth, and we'll also use an empirical strategy related to the fraction of a baby's neighbors who are born in public facilities. So let me start by defining what I mean by skin-to-skin care. So the WHO recommends that immediately after a birth, providers place a dried newborn on the mother's belly or chest and perform essential checks for the baby's breathing, color, and tone while the baby is on the mother's chest. The WHO encourages providers to do skin-to-skin contact between the mother and the baby for about 60 to 90 minutes and to assist with the first breastfeeding right there after birth. They recommend delaying taking the weight and providing a vitamin K injection or eye ointment or other interventions until this so-called golden hour of bonding between the mother and the baby has occurred. And I want to point out that, this description is what's recommended, but it may not necessarily be what mothers who report receiving skin-to-skin care in the DHS have gotten. They would have no way of knowing that these were all of the components of it. They're simply going to answer the question that was asked, which I'll share with you guys in a minute. But before I do that, just to build our understanding of skin to skin care a bit more, I wanted to mention what the benefits of this practice are. So it leads to the relaxation of the mother and the baby, the stabilization of the baby's vitals and temperature, the colonization of the baby's skin with the bacteria that's on the mother's skin, and it stimulates hormones that promote breastfeeding and bonding. And so knowing this, it's not a surprise to me that this practice has been recommended for all babies, including premature and low birth weight babies who are considered at highest risk of death, and that we're finding evidence that suggests that it is protective of newborns in this context. So let me tell you a little bit about how the DHS asks about skin-to-skin care. So the DHS codes a baby as having received skin-to-skin care if the mother answers yes to both of the following questions. Immediately after birth, was your child placed on your chest, and was your child's bare skin touching your bare skin? And the results that I'm going to show you for the rest of the presentation, use the NFHS 5 data from rural Uttar Pradesh and Bihar. And so these are the two most populated of the North Indian states that we looked at before, and they're also the states that have the highest public-private gap. So now we turn to the NFHS 5 data, and we first replicate the pattern that we were looking at before. So the graph labeled 1 all the way on the left is the neonatal mortality difference between births in private facilities and births in public facilities. That remains similar and large. And then we see about a 15 percentage point difference in responses to this skin-to-skin contact variable. And unlike the breastfeeding variable, it has a very low rate of missing data, both among surviving babies and among babies who died. And then finally, we look here at graph number 3, which is going to show us the neonatal mortality among babies who did not receive skin-to-skin care. And in graph number 4, neonatal mortality among babies who did receive skin-to-skin care. And so I want you to notice the overall level differences between these two graphs. Babies who received skin-to-skin care, whether they were in public or private, had much lower mortality than babies who did not receive skin-to-skin care. And this graph suggests an interaction between place of birth and receipt of skin-to-skin care, where babies who don't receive skin-to-skin care are much more disadvantaged if they are born in a private facility relative to a public facility. So as before, we're still thinking about ruling out selection. And one way to put it in this case is, how can we rule out that mortality differences arise because the place of delivery is chosen based on facts that are unobservable to us about the frailty of the baby? And so that could be about the health of the mother, how the pregnancy is developing, or something going on with the baby. And so in order to try to rule that out, we construct a new variable that is the fraction of a baby's neighbors that are born in public facilities. So the Demographic and Health Survey is a clustered design, or it has a clustered design, where the primary sampling units, there are several households from each primary sampling unit that respond to the survey. And so here we look at the count of births among a baby's PSU neighbors in public facilities in the last 5 years, divided by the count of births in any facility in the last 5 years, excluding that baby. And so the advantage of this variable is that it strongly predicts whether or not the baby was born in a public hospital, but it is not caused by the baby's own health, whereas place of birth may be. And as I'll show you on the next slide, it otherwise predicts disadvantage. So in this graph, what we've got on the horizontal axis is that variable that I described on the last slide, the fraction of a baby's PSU neighbors born in public facilities. And on the vertical axis, we have correlates of mortality that are scaled by standard deviation of that variable, and they're signed such that positive values predict survival. So what we see is that the neighborhood fraction of deliveries in a public facility predicts baby level disadvantage for household wealth, for whether or not the household owns a toilet, for the mother's height, for literacy, for electricity, and for family size. However, the one variable for which the fraction of a baby's PSU neighbors born in a public facility predicts advantage is the receipt of skin-to-skin care. So if more of your PSU neighbors are born in a public facility, you're much more likely to receive skin-to-skin care at birth. And so now in this graph, we're going to be looking at the relationship between that variable fraction of a baby's PSU neighbors born in a public facility and the likelihood that that baby survives. And we see with the upward sloping dark line that there is a very strong positive relationship between the fraction of babies of a baby's PSU neighbors born in a public facility and survival. But that no longer predicts survival once we account for skin-to-skin care. And so the way that we account for skin-to-skin care is simply by splitting the sample. So the blue dashed line is births that receive skin-to-skin care, and the red dashed line is births that do not receive skin-to-skin care. And so once we've accounted for the receipt of skin-to-skin care, that variable fraction of PSU neighbors born in a public facility no longer has predictive power. And I don't show it up on the slide, but for those of you who just want to take the analysis to the next logical step, if we regress neonatal mortality on skin-to-skin contact using the fraction of PSU neighbors born in a public facility as an instrument for the receipt of skin-to-skin care, we see a large negative relationship between neonatal mortality and skin-to-skin care, about 50 per thousand. And so, we think this is beginning to suggest that skin-to-skin care is one, quite protective, and secondly, that this the differences between this practice could represent important quality of care differences that may be explaining why survival is so much better in public facilities than in private facilities. So just to summarize where we've been in the talk, we've seen that babies in rural North India born in private hospitals are at very high risk of death. That selection may be an important part of why that difference exists, but it's certainly not the only difference. We looked at many subsamples of varying risk, and we saw the difference in all of them. We talked a little bit about breastfeeding and dug into differences in postpartum skin-to-skin care. Building an argument that quality of care differences exist between these two types of facilities. So I think a couple of policy suggestions that come out of this body of work is the need to regulate private providers. And we have seen in some of the states that there's better regulation of maternal and child health providers than there is in other states. And I think another thing that comes out not only from this paper, but from the literature on skin-to-skin care and kangaroo care, that health departments and medical education institutions should really emphasize this practice in all types of hospitals and for nearly all births. And in future work, I'm looking forward to qualitative interviews to help understand the extent to which the demographic and health survey questions capture skin-to-skin care as described by the WHO, or really whether this is a marker for other indicators of quality, and to try to investigate the role of a broader set of quality of care practices for labor and for birth. So thank you so much, and I look forward to your questions.
Thank you for this fascinating talk, Diane. Now the floor is open for questions. Those of you who would like to pose the question can do so by, turning on their screens and asking the questions, or just posting it in the chat box. As the questions come in, Diane, I could start by asking a few clarification questions. So
Sure.
uh, it's really fascinating what you have shown through the data. And I was wondering if you are accounting for, and perhaps you mentioned it and I missed it, which is that uh, to what extent does the delay in providing such care for cesarean deliveries, right, be sort of responsible for some of these results that we are seeing? So clearly, women who've had cesarean deliveries would be, I'm assuming, less likely to provide this care.
So are you saying that, like, imagine somebody is having a pregnancy that's developing such that they will require a cesarean birth. The lack of prenatal care could mean that they end up delivering in a private facility because there's so few cesareans provided by the public facility. And it was already a high-risk pregnancy, and it ended up in the private sector. So could that be responsible for our gap?
Sure. So I know you already accounted for delivering, right? And some of the prior selection. But here the question is just about the nature of the delivery. So even for sometimes we understand, especially with the data coming in from JSY, Janani Suraksha Yojana, that we have seen an increase in cesarean births in India, and in neighborhoods where there isn't a public facility which can cater to cesarean births, people are referred to private facilities, right? So in many ways, this is driven, in some sense, by the scheme per se. So my question is, because the way cesarean deliveries perhaps are carried out, could sort of prevent the mother from immediately holding the child for an extended period of time. And so that may then also play a role in driving perhaps some of these results.
Yeah, yeah. So I think it's interesting that you bring this up. You pointed out that when cesarean births happen, it's not common practice either in India or in many other places to do immediate postpartum skin-to-skin contact. So it's then somewhat surprising to me that some women in the DHS who have gotten cesarean births do report skin-to-skin contact. So I think it's worth understanding that a little bit better because I think it's a sort of public health priority, not only in India, but also other places to start what's called a gentle cesarean, which has a number of practices associated with it, but it also includes allowing that skin to skin time to happen.
Thank you.
And it
Thank you.
would be really interesting to see the effect of getting that started here on neonatal mortality.
Mhm. It would sure be. We have a question by OJ.
Hi, nice to meet you, and thank you for the great talk. Can you hear me?
We can.
Yes.
Oh yeah, I'm an assistant professor of sociology at the Singapore Management University. Oh, I have two questions. So first, I was really surprising to me that we see this huge differences in neonatal mortality between private versus public sectors hospitals in the North India, but not in the other regions. So I was wondering whether there's any skin-to-skin care gap between private versus public hospitals in other regions of India, not the North India. So my first guess is that there might not be a gap in skin to skin care. There might be one explanation for why we don't see this pattern in other regions. Or maybe if there is a gap in the skin to skin practices between those two types of hospitals in other regions as well, it might be that their differences would not have the effect on the neonatal mortality in the context other than North India. So I was wondering whether it's a skin to skin care per se the effect of that per se, or it's the interaction with the context-specific factors in North India? That's my first question. And the second question is how you conceptualize this skin to skin, whether do you think the differences we see in the neonatal mortality, do you think that's an effect of the skin to skin per se, or whether you think the skin to skin as a one measure of broader composite of the quality of care differences between private versus public hospitals?
Great, thanks. So we haven't done the analysis that you recommended yet, but I think it's a really logical next step, and thank you for bringing it up. So, as I understand you to have said, we should look for a gap in skin-to-skin care between public and private facilities in the South, and then think about, whether we think that skin-to-skin care matters in that context. And I think what you're pointing towards is that both the public and the private facilities in the South likely have better trained and more well-resourced staffs. And so does skin to skin matter as much for survival if there are other ways of making sure that the baby is well monitored and thermoregulated other than skin to skin care? So that's a great question, and thank you for bringing it up. And then you were saying, okay, do we think that this is the suggestive evidence towards a causal effect of skin to skin on survival? Is that really skin to skin itself, or is it a broader set of practices happening in public facilities? I expect it's a broader set of things happening in public facilities. So, just from being in this world, I've seen differences in vitamin K injections, for instance, where that's a really kind of a no-brainer neonatal health intervention. It helps babies survive the first month by reducing bleeding deaths, and the public sector stocks them. The private sector doesn't. We also saw quite a bit of evidence from the qualitative interviews from the paper I mentioned that the public sector has backed off from and never really in the first place had a good incentive to make births happen earlier than they otherwise would. But the private sector, if they have a patient there who they would like to pay them for the birth, may sort of push the mom to deliver the baby earlier than she might otherwise. And we know that premature birth is really dangerous for survival.
Thank you so much.
Thank you.
As we are waiting for other questions to come in, have you explored some of the facility data in the DHS on this, especially, building on the work of Jishnu Das and others, right, which speak about just the poor quality of care provided in public hospitals and public clinics in North, particularly. How do we, is there a way in which you can account for this quality of care with the existing data?
So we've been trying to think about more things that we can do. One question that I've thought we could turn to next is, okay, well, what sort of provider delivered the baby? And where I think that we may run into problems with that is that the patients may not know, was the person a doctor, was the person a nurse, or was the person untrained? And so if you walk into a private hospital, for instance, they're going to call the woman the nurse whether or not she has a nursing degree. And there's really not a way for the patients to know what the background of the provider is. So we may be limited with that one, although there are a number of other questions about, say, whether the baby was checked at all, whether the baby's temperature was taken at all, that we can start to look at. So those are things that the patients could have recognized. Another thing we've thought of is whether or not the baby was weighed matters. And now almost all babies are being weighed, but so demographers get excited about age heaping. I'm excited about weight heaping. So if the moms are reporting a less heaped weight, we think that the providers will have done a better job weighing the baby. That might be another indication of quality of care.
Interesting. Thank you. That's a really neat suggestion to think about. Quality of data.
Care. Yeah.
Do we have other questions? Because, I have more. So, oh, we have Fanian here. Wonderful, Fanian,
Oh,
please.
so can I ask a question? Fascinating talk. I learned so much. I also want to quickly ask Diane, like, um, DHS data in other contexts, are there similar work looking at the skin to skin contact? I think I've read some work on in Bangladesh, or can you speak to a little bit about like work in other contexts in
I really
comparison with?
should be able to. So this is our this year's PAA submission, and we have a little bit more work to do on it. But we were just throwing around the idea yesterday that we should look at both skin-to-skin contact in other countries. It's a pretty new DHS question. And then another thing that I'm wanting to do is say, okay, public facilities in other countries, how does their mortality and these different practices compare to public facilities in different states of India? I think it would make sort of an interesting comparison to say, okay, well, Bangladesh's public sector is performing like this, and this state, but these states are not performing as well. Overall, it's pretty high. Like I've done the DHS stat compiler of the skin to skin contact variable in other countries, and um, India's kind of the middle of the pack or the higher end, but I think it's got to be capturing some other things because I it just looks too high, and that's a smell test. So I think that's part of why I'm excited about jumping into this qualitative work to really try to understand like what do people mean when they say it. So the translation of the Hindi question is closer to did you hug the baby after birth than was the baby placed on your so sine se lagana is the Hindi for it, and it literally means place on your chest, but people understand it broadly to mean hug. And I think a lot of people wouldn't say, no, I didn't hug my baby after birth. And then it becomes the clarification of, okay, well, was their bare skin touching your bare skin? And then you can try to understand it a little better.
Mhm.
Yeah, that's fascinating. You can look into the qualitative data for
Yeah.
further evidence and all that. And then DHS by itself, there are not no other markers you can explore, right? This is pretty much the
For skin to
only,
skin in particular, this
yeah,
is the
to sum
only
that
one, but
question, right? Mm-hmm.
some other quality of care measures will be there.
Mm-hmm. And you did, I mean, look at
Uh,
like, at all, no, okay.
cord cord is pending, weight heaping is pending. There's been a pretty there's a difference between the NFHS 4 and the NFHS 5. So we're seeing increasing quality for both quality and quantity of data collected on, say, birth weights. So it's going to be much more usable in the NFHS 5.
Mm-hmm. That's great. Thank you so much.
Thank you.
You. I was also wondering, Diane, is that the way skin to skin care is visualized, and even in the picture that you showed in the beginning of the presentation, right, where the woman is not clothed, right? But this is
Yep.
something so rare in India, even during delivery, right? So,
Right.
across, public, private, or so, skin to skin care is primarily just the neck, right? I mean, that's the extent of skin to skin contact that would be provided to a child. I'm assuming,
I think
or
a lot of people don't have their saris on in order to prevent them from getting ruined. So they would most Hindu women I tend to see giving birth in a skirt, and then having the sari like way far up, and maybe not even there. So it's really the blouse that would prevent the skin to skin
exactly,
contact.
exactly, it's the
Um,
blouse,
yeah,
right? Because there are, I find it hard to visualize that the blouse will be off, right?
it won't be off. Yeah. So then it's up to the woman's interpretation whether that blouse prevents the skin to skin contact or not.
As you do these global analyses, perhaps, you could also, it's just impossible to do, but you don't have data. but just
Right. Yeah. I don't know what women wear in Laos, for
yeah,
instance. Right.
exactly, right. So then the both the extent of skin contact, right, the duration of skin contact, like important features, something that whenever that we resume data collection, our features
Right.
are features that could be worth exploring because clearly your research is quite interesting and throwing up fascinating results. The
Yeah.
population.
I mean, I would hope that one day the DHS would be in a position to have more detailed questions on like how hospitals' practices match the WHO's recommendations.
Mhm. Okay. We are almost out of time here. If we have any last questions, we can ask them now. But otherwise, I'd like to thank Diane for taking the time out of her busy schedule, specifically that she's traveling to India with little ones. I'm really very grateful for sharing this interesting and potentially extremely important research, hopefully driving, some of changes that can happen in North India, where we know that there is a dire need to find ways to prevent mortality. I think we have a question in the chat box. Oh no, just people thanking you for a wonderful talk. So before I let the audience go, I'd just like to share information about the next talk. This will be an in-person talk. Which will happen on the 3rd of March by Professor Zachary Zimmer from Mount St. Vincent University. He will be talking about early life war trauma and later life health with a focus on Vietnam. Uh, since we have OJ here, I'd also like to share our next talk, which would be by OJ, who will be speaking about deinstitutionalizing overwork and women in the workplace, also in the same week on the 7th of March. So thank you so much for joining us and look forward to seeing you for the next talk. Thank you, Diane. Thanks,
Thank
Fania.
you.
Thank you so much.